Welcome to this deep dive. If you're an orthopedic resident gearing up for those really tough postgraduate exit exams, the FRCS, or a fellowship equivalent, then, success really hangs on nailing the specifics, the high-yield technical stuff.
Absolutely. Every detail needs to be right there, ready to recall under pressure.
So today we're focusing on two particularly challenging areas, ones that definitely come up: revision ACL surgery and ACL reconstruction in skeletally immature patients.
That's right. The goal here is to really distill the technical know-how. We want to cover how you assess why a graft failed, and then really master those physical-sparing principles for younger patients. It's precision stuff.
And just to be clear for everyone listening, this discussion is grounded in the excellent Ortho Made Simple notes. You can find those online at mokyingren.sg.
Yeah, they're a fantastic resource.
They were put together by Dr. Mok Ying Ren, who's a sports surgeon over at National University Hospital in Singapore. He completed his FRCS in orthopedic surgery from Edinburgh, so really solid grounding for this. Okay, let's unpack the first big area: revision ACL failure. When a patient comes back with a re-ruptured ACL graft, the absolute first question, certainly in the exam setting, has got to be why? Why did it fail?
Exactly. Before you even think about fixing it again, you need the diagnosis of the failure.
So what are the sort of categories? I understand there are three distinct types of, let's say, abnormal graft motion that can lead to that mechanical failure.
Yes, this is fundamental. We typically think about it in terms of the vector, the direction of the unwanted motion. First up is the windshield wiper effect.
Okay, windshield wiper, what does that look like?
So picture horizontal or sagittal plane movement. The graft is essentially moving side to side within the bone tunnel. Think of it like a pendulum. That motion causes friction, abrasion, and eventually the graft loosens up, becomes slack.
Right, so sort of perpendicular to the graft's main axis?
Yeah.
Got it. What's the next type of motion? Is it along the axis then?
Precisely. The second one is the bungee effect. This is longitudinal movement, kind of like a piston or telescoping. The graft is stretching and then recoiling back and forth within the tunnel.
And what causes that? Poor fixation.
Often, yes. It could be inadequate initial fixation, maybe poor tensioning to begin with, or maybe the fixation has loosened over time, allowing that stretch recoil cycle.
Okay, windshield wiper, bungee effect. And the third one, I remember reading it's often a bit more insidious, not so much an acute motion.
That's a good way to put it. The third mechanism is creep. This isn't about gross movement like the other two. It's a gradual, sort of viscous elongation. The graft material itself permanently stretches out over weeks, months, even years.
Under normal load or excessive load.
Usually under continuous cyclic loading that's maybe just slightly below its ultimate yield strength. It just slowly deforms over time. Understanding which of these three, windshield wiper, bungee, or creep, was the main issue really helps guide how you approach the revision, especially regarding fixation and tunnel prep.
Fantastic breakdown. Okay, so knowing those potential mechanical failures, let's translate that into the clinic. When you're taking the history, doing the physical exam for a patient with a suspected re-rupture, what are the specific red flags or, deeper issues you must look for beyond just the mechanism of the new injury? We're sort of hunting for things missed the first time around, right?
Exactly right. You have to be a detective. The history isn't just about the recent event. You absolutely must explore if there is an underlying, perhaps untreated instability issue from the start.
Like what specifically?
The big ones are a missed posterolateral corner injury, the PLC, or perhaps the patient have significant rotational malalignment, like excessive internal tibial torsion, that really necessitates a tibial rotation osteotomy, or TRO.
Ah, okay. So if that background rotational instability isn't addressed?
Then the new ACL graft is subjected to forces it just wasn't designed to handle. It's almost set up to fail again, no matter how well you place the graft itself. You've got to treat the whole knee stability profile.
That's such a key point. It's not just an isolated ligament problem. So in the exam room, obviously, you do your standard test, Lachman, anterior drawer. But what's the one physical exam test that becomes absolutely mandatory in a revision setting to specifically screen for that potential missed PLC injury?
Yeah, beyond the standard ACL tests, the critical addition is the dial test. You have to perform this.
Okay, walk us through that briefly.
You perform it with the patient prone, assessing tibial external rotation compared to the uninjured side. You do it first at 30 degrees of knee flexion and then again at 90 degrees.
And what are you looking for?
You're looking for an increase in external rotation, typically more than about 10 degrees compared to the normal side. Critically, if that increased rotation is present at 30 degrees and either stays the same or worsens at 90 degrees, that strongly suggests a significant PLC injury. You simply cannot proceed with just an isolated ACL revision if the dial test is positive like that. You have to address the PLC.
Right. You'd be setting the patient up for failure number 3 otherwise. Okay, so let's say the clinical picture, maybe the history of the first failure being non-contact, points towards a technical issue with the original surgery. That leads us to imaging, right? Usually a CT scan to really map out those old bone tunnels.
Correct. CT is invaluable here for the bony detail.
So what are the key landmarks, the measurements, the angles you absolutely must verify on that CT scan, looking at the tibia and the femur?
Okay, starting with the tibia, in the sagittal view, you're looking at placement. The ideal tunnel should be posterior, and critically, it needs to run parallel to Blumenstock's line when the knee is viewed at a 30-degree angle of flexion on the scan or reconstructed view.
That 30-degree angle seems really specific. Why is that so critical? What happens if it's off?
It is incredibly precise, and yes, it's crucial for the exam. If that tunnel is too anterior relative to Blumenstock's line at 30 degrees, you risk notch impingement when the knee extends. If it's too posterior, you risk impinging on the back, the PCL, or the roof in deep flexion. It relates to isometry.
Okay, so parallel to Blumenstock's at 30 degrees for the tibia. What about the femur? We need to look in both sagittal and coronal planes there, right?
That's right. Sagittally, you're looking at where the tunnel exits relative to the intersection of the posterior femoral cortex and Blumenstock's line. You don't want it too anterior, as that compromises isometry, meaning the graft tension changes too much to the range of motion.
And coronally.
In the coronal plane, you're assessing for excessive verticality. A tunnel that's too vertical, again, leads to poor isometry. It'll be super tight in flexion and loose in extension, leading to stretching or creep. You also check for tunnel divergence if multiple bundles were used. And crucially, across both tibia and femur, the CT is assessing bone stock. Is there significant tunnel widening? That's vital for planning.
Right, the tunnel widening. That really dictates the next steps. So taking all that imaging information, tunnel position, angle, bone stock, what are the main management scenarios you face in the OR? How do you decide what to do? Can you outline those key options, especially mentioning when you have to consider bone grafting?
Yeah, it really boils down to 3 main scenarios based on that CT assessment. Scenario 1, the tunnel position is just plain poor. It's biomechanically unsound, maybe too vertical, too anterior. In that case, you pretty much ignore the old tunnels and create entirely new anatomically correct tunnels.
Okay, new tunnels if the old ones are bad. What if they're in a decent spot?
That's scenario 2. If the tunnel position is good, anatomically acceptable, then you can often reuse them. You might need to upsize your revision graft slightly, maybe go from an 8mm to a 9mm or 10mm, just to fill the existing space snugly and get good fixation.
Makes sense. And scenario 3, that's the tricky one with bone loss, right?
Exactly. Scenario 3 is when the tunnel position is good, but there's significant bone loss. We typically define significant as tunnel widening maybe greater than 15mm, or if you've lost roughly half the original tunnel diameter in bone stock.
And in that case,
In that situation, you really have to consider bone grafting. This might be possible in a single stage if the defect isn't enormous, packing graft around your new ACL graft. But more often, especially with large defects, you're looking at a 2-stage procedure.
2 stages. Why is that often necessary? Why not just pack it all in at once?
It's about biology and structural integrity. In a 2-stage approach, the first operation involves cleaning out the widened tunnels completely, debriding any fibrous tissue, and then packing them firmly with bone graft. Could be autograft, maybe from the tibia or iliac crest or allograft.
And then you wait.
Could you wait, usually around 4 to 6 months. You need time for that graft to incorporate, to consolidate, to actually remodel into solid host bone. It needs to restore the structural integrity of the scaffold for your future graft. Only then, in the second stage, do you go back, re-drill through that now solid bone, and place the definitive ACL revision graft.
So trying to do it all at once with major bone loss just risks the fixation pulling out.
Absolutely. You'd be placing a high-tension graft into what's essentially mush. The fixation would almost certainly fail. Rushing, it leads to disaster. That 2-stage approach is often crucial for success in these complex cases.
That's a critical point for residents to understand. Patience and biology matter. Okay, while we're on complex revisions, what about adjunct procedures? We hear about lateral extraarticular tenodesis or LET. What's its role here? When should you consider adding an LET?
LET is definitely something to have in your armamentarium for revisions. Its main role is to provide additional rotational control, particularly against excessive tibial internal rotation, which is what happens during the pivot shift.
So when is it most indicated?
You should strongly consider adding an LET when the risk of residual or recurrent rotational instability is high. Think about patients undergoing revision who might also have some associated laxity, maybe borderline PLC insufficiency, or those who present with a really high-grade pivot shift even before the revision. Also in cases of chronic ACL deficiency or multiple failed reconstructions.
So it acts like a backup.
Kind of, yes. It acts as an external check crane, helping to protect the intra-articular ACL graft from those excessive rotational stresses, potentially improving the longevity of the revision.
Okay, great. Now, let's shift gears to the other really complex area, ACL reconstruction in skeletally immature patients. Managing those open growth plates, the physies, this is where things get really interesting and potentially risky if not done right.
Absolutely. Growth disturbance is the major concern here.
So when you absolutely cannot or do not want to drill across the growth plates, what's the classic sort of go-to physical sparing approach that residents really need to know inside out for their exams?
The key concept here is extra-articular or combined extra-articular techniques that avoid the physis. The one that often comes up and is a modification of an older technique is the Kocher technique. It's essentially a modification of the Macintosh procedure, but adapted.
The Kocher technique. Okay, can you walk us through how that works? What tissue is used and where does it go?
Sure. The Kocher technique typically uses a strip of the patient's own iliotibial band, the ITB. It's harvested proximally, leaving its distal attachment intact.
Okay, so a strip of ITD.
Yes. Then this strip is looped around the lateral femoral condyle. That's the key femoral anchor point, staying completely outside the physis. Then, crucially, it's passed through the intercondylar notch, over the top.
So it does go intra-articular.
It has an intra-articular component, yes, passing through the notch, which helps it mimic the ACL's path to some extent. And then it's attached distally to the proximal tibia, often near Gerdy's tubercle, again, avoiding the tibial physis.
So it provides rotational stability without drilling tunnels across the growth plates.
Exactly. It primarily functions as a non-anatomical restraint, particularly good at controlling that pivot shift without violating the physis.
And just for context, how did the original Macintosh procedure differ? What was its core principle?
The original Macintosh was purely extra-articular. Its principle was just reinforcing the lateral structures to limit pathological tibial internal rotation. It also used an ITB strip, but it was typically dissected out, passed deep to the lateral collateral ligament, maybe through a small superiosteal tunnel on the femur, and inserted into the lateral femoral condyle area, entirely outside the joint, focused only on lateral restraint.
Okay, so Kocher is more intra-articular focused while still being physical sparing. Now, sometimes, especially in older adolescents nearing skeletal maturity, surgeons might opt for a transfascial technique actually drilling across the growth plate. If that decision is made, what are the absolutely critical strategies, the sort of non-negotiable rules, to minimize the risk of damaging that physis and causing a growth problem? There are about 4 key ones, right?
Yes, there are 4 crucial rules you must follow if you drill across an open physis. These are all aimed at minimizing trauma, especially thermal injury and mechanical disruption. First, limit the tunnel diameter. Keep it small, ideally 8 millimeters or less. Smaller hole, less physis damaged.
8 millimeters max. Okay, what's number 2?
Second, use more vertical tunnels. Think about the geometry. A more vertical tunnel crosses the physis over a smaller surface area compared to a more oblique tunnel, again, minimizing the footprint of the violation.
Right, less cross-sectional area damaged. Makes sense. What about the actual drilling and fixation?
That's rules 3 and 4. Third, you absolutely must drill the tunnels at a lower speed. High-speed drilling generates significant heat. Heat is extremely toxic to the chondrocytes in the physis. It can cause thermal necrosis and lead directly to growth arrest. So, slow-speed drilling is essential.
Minimize thermal injury. And the last rule, fixation.
Exactly. Fourth, you must avoid using interference screws for fixation right across the physis. Those screws work by expanding, creating compression for graft fixation. That compressive force and the screw threads themselves can mechanically disrupt the physis, causing significant damage and potential growth disturbance. Soft tissue fixation methods, or fixation away from the physis, are preferred.
Okay, those 4 rules. At 8 millimeter tunnel, vertical orientation, low speed drilling, avoid interference screws. That's a vital checklist. Lastly, let's touch on partial physical sparing techniques. Sometimes, maybe due to anatomy or surgical choice, only one physis can be fully spared. If you have to choose between sparing the femoral physis or the tibial physis, which one must you prioritize, and why is this so critical based on growth contribution?
This is a really important anatomical and developmental point. If you have to choose, you absolutely prioritize sparing the femoral physis.
Spare the femur. Why?
It comes down to the relative contribution to lower limb growth. The discal femoral physis is a powerhouse. It contributes roughly 40% of the entire lower limb's length growth.
40%? Wow, that's huge.
It is. In contrast, the proximal tibial physis contributes significantly less, around 27% of the total lower limb length. So damaging the femoral physis carries a much higher risk of leading to a clinically significant limb length discrepancy or an angular deformity as the child continues to grow. Sparing the femur gives you the best chance of avoiding those major long-term problems.
That 40% versus 27% difference is the key takeaway there. It dictates the safer choice if a full sparing technique isn't possible. Okay, let's try to summarize the absolute must-know points for exam readiness from this deep dive.
Right.
For revision ACL, you need to clearly define those three failure mechanisms: windshield wiper, bungee effect, and creep. And critically, always suspect and rule out underlying rotational instability, especially that missed PLC injury. Use the dial test.
Absolutely. And on the imaging side, visualize those landmarks.
Yeah.
Tibial tunnel, posterior and parallel to Blumensatz's line at 30 degrees. Femoral tunnel, assess position relative to the posterior cortex and Blumensatz's, and check verticality. Know when bone loss dictates grafting, often a two-stage approach if widening is significant, say 15 millimeter.
Then for pediatric ACLs, be ready to describe a true physial-sparing technique like the Kocher modification using the ITB. If going transphysial, know those 4 rules by heart: small tunnels, vertical drilling, low speed, and no interference screws across the physis.
And finally, that crucial anatomical ratio. If you must choose, always prioritize sparing the femoral physis, because its 40% growth contribution poses the biggest risk for deformity if injured, compared to the tibia's 27%. Understanding the why behind these technical choices is really what makes the difference.
This has been incredibly detailed. A reminder that this deep dive was based on the Ortho Made Simple notes, which you can find at mokyingren.sg. Really valuable stuff there.
Definitely worth checking out. Hopefully mastering these points helps you walk into those exams with confidence.
Indeed.
And as we close, a word of encouragement. So you will find favor and good success in the sight of God and man. Proverbs 3.4. Go well.